Good morning. I thank the chairperson for the kind words of introduction and Professor Mohan and team for the kind invite which has been happening for decades, so that the deep respects to Professor Mohan, who taught me the ABC of diabetology when I was a postgraduate student. As Professor Ashraf just now said, that we have been conferences after conference, we have been talking about how to initiate and escalate therapy and how to remove the clinical inertia, the therapeutic inertia. Same way, we also should know that how to do justice to a subgroup of people, the vulnerable population, who are an older diabetic patient whose age is more than 65. So I don't have any conflict of interest, and photographies are allowed for postgraduate if we find some slides are useful. So worldwide, 20% of patients over the age of 65 have type 2 diabetes, and by 2045 it has been projected that almost 300 million population would have diabetes at that age group. And of course, the risk of hypoglycemia is particularly important in these patients. So to address the risk of hypoglycemia and adverse outcomes, we have multiple guidelines which recommend higher glucose targets, avoidance of overtreatment, and definitely we'll have to give a personalized treatment for these people. So for this, there is a particular steps that need to be taken. This is the art which I am going to talk about, which was initiated by a consortium group which happened in 2023 and got recently published in Lancet Endocrinology. These are the 4-step or the 4S pathway. Step 1 looks into the triggers which have produced a landfall in the patient's management. So when I am talking about this pathway, we are going to talk about people who require special attention. Not all old people require this kind of pathway. If a person is old but fit and he is mobile, his comorbid conditions are bare minimal, I think they can follow the traditional guidelines, that individual guidelines that is being prescribed by various agencies. But when we have people with symptoms or factors that can impact their diabetic goals, then these are the patients which we need to have some shared decision taking. That is the step 2. Then we have to set, and probably during the course of a treatment, we have to reset their treatment goals, because that is where we don't want a person to go into hypoglycemia and related bad outcomes. And of course, we'll have, so now you know that the last 15 years, we have been bombarded with so many new current classes of drugs and treatment available, but we cannot give all those drugs to these people. They have to be simpler and safer medications, taking care of the current lifestyle of the patient, the social status, as well as the system, the support system the patient is having. And you know that these days that most of the elderly people are either in a gated community or an old age home, or being taken care by people coming, people who are probably not related to medicine, but just taking care of these old people at home, where their children, grandchildren are going for work. So we have a problem with this set of people. So let us look at by each step. So here, before we start, I like to gather the attention of the audience that till now we were talking about HbA1c for all the glycemic control. If you want having, everything is targeted based upon your A1c. But in this population, probably A1c takes a back seat. A1c has a very limited source or usefulness as a metric in elderly people. The 3 months average does not help you in detecting hypoglycemia or glycemic variability. A1c might not be accurate, as you know, in people with chronic kidney disease because of anemia, as well as any reasons that patient had a recent blood loss. Elderly people, even though with relaxed A1c, does not protect them from hypoglycemia. So glucose monitoring, either by continuous glucose monitoring or by finger stick blood glucose, that is self blood glucose at home, is recommended as a complementary approach, as a guide to treat and make the necessary adjustments. So let us look at this step 1, which are looking at the triggers. So in this, you can see that any medical event that can produce an important outcome, for example, a medical event like a fall, accidental injury, or a life-altering event, death of the spouse or a death of a caregiver, or a change in the physical or cognitive or a mental health status, that is in the form of a stroke all of a sudden patient had a stroke or a myocardial infarction, or he has to be hospitalized for some reasons for very number of days, or medication red flags, for example, inappropriate prescription, high number of medications. So, because the pill burden can probably confuse the patient whose cognitive function may not be appropriate, and probably he can be missing the prescription, and complex regimens. For example, if the patient is having insulin morning, he gets 50-50, afternoon he gets a short-acting bolus or a prandial insulin, and night he gets 30-70. There is always a chance that he can change or miss the doses or exchange the insulin regimens. So, if you are looking at this particular slide, you have on your right, you can see, on your left, you can see the various triggers, for example, a fall or a confusion or a delirium or a cardiovascular event, or patient has nocturnal polyuria by which his sleep is also being disturbed. I think we need to find out what are the possible diabetes related cause or the contributing or the confounding variable factor. If you can see that most of the things, if it is allied with hypoglycemia, especially nocturnal hypoglycemia has taken into consideration, and also you have to look into what can be done as an action plan. So, in these patients, probably the action plan is to review the medication. One important thing that I like to want all the audience to, and especially the young minds to look, is that kindly do reconciliation of all the prescription. Patient may come to us for diabetes management, will go to a psychiatrist for his sleep related issues, will go to a cardiologist for his cardiac issues. So, there are a lot of prescriptions will be there, and patient will tell us that he is only taking certain OHs or insulin. We need to know from the patient's side all the prescriptions so that we don't duplicate it, and we also see there are no drugs which can have a drug-drug interaction. So, number 2 will be the shared decision making. We shall not thrust any of our ideas to the patient unless until patient also agreed upon. There are so many examples I have given. For want of time, maybe I can take one example, that is the looking at the glycemic goals. As you all know, that we can't have a stringent glycemic target of A1C of say some 7 in these patients. We need to probably relax the strategy, get the A1C to 7.5 or 7.8 as the case may be, definitely below 8%. For that, how do we address it? Low A1C is not beneficial and may be harmful in such patients because that can lead on to hypoglycemia related events. So, what is the concern of the patient? Patient says that I have always been under very tight control, and I found it always good for me. But here, what could be our response? That we manage diabetes with the goal of improving your overall health. It is just not one metric that we are interested, and the tight control does not always give you or reflect as an improvement in the quality or quantity of life. So, this is a kind of a shared decision, the conversation that has to happen between the primary caregiver and the patient or the family. Everybody should be the conversation should be happening across the table. Now comes the setting and the resetting of the goal, that is step 3. So, high proportion of diabetic patients are probably may be the risk of over treatment with oral hypoglycemic agents. So, over treatment of these drugs is associated 73% increased risk of mortality relative to an appropriate glucose lowering, that is getting the A1C to target. Whereas glycemic under treatment does not probably relate to increase in the mortality. So, this is a kind of a tight ropeway that we need to walk, so making sure that patients' quality of life does not get endangered as well as the mortality is not increased. So, when individualizing glycemic target, the priority in older patients, reducing the risk of hypoglycemia is very important. Decreasing the glycemic excursions, because we are also talking about glycemic variability, which probably an A1C will not pick up, and maximizing the amount of time the person spends in their individualized target range. You know that for all reasons we keep the target between 70 to 180 for all the patients, and we expect that in elderly people 50% of the time is spent in what you call time in range, and only less than 1% should be time below range. This is what an accepted guidelines, and this is what we would like to have our patient to have. So, finally, a frequent or prolonged glucose values of more than 250 should be avoided to minimize the acute complications of hyperglycemia such as dehydration, infection or an rapid cognitive decline. So we need to have a way to analyze this, and this can be done only by glucose monitoring. So glycemic pattern becomes much more important than HbA1c value per se. And how we do it, and that is the last one, that is the prescription. And regimens should be tailor-made to the person's type of diabetes, whether it's a type 1 or insulin requiring type 2 diabetes, functional status of the patient, which is the main predictor of both total as well as healthy life expectancy, cognition, his current physical health and other comorbidities. So personalized treatment should always look at the harm versus the benefit ratio. If benefit is more, please continue the treatment. If there is going to be harm, I think we need to de-prescribe or de-escalate the therapy. And this is an example that I would like all of you to focus. So till now we talk about theory. Now let us go to a practical point of view. Here we have an elderly person, maybe age of 65 or 70, with an A1C of 7.6%. So if you look at the target A1C, he looks very good. It's very, it comes well within the target. And you can see that in this, the one which is in the red tells you about he is having hypoglycemia, and this is an 14-day period that has been 14-day periods of CGM that has been superimposed. And what could see in this pattern is that he is getting hypoglycemia which is recurring every night, and he also gets hypoglycemia that occurs after every meal, that you can see at 10 a.m., at 1 p.m. and probably around 4 p.m. He is getting hypoglycemia. He is getting 10 a.m. as well as 1 p.m. and in the evening also, and he also has hyperglycemic episodes. There are surges of hyperglycemia following which he has a hypoglycemia, that is at 7 p.m. if you look at all the arrow marks. Okay, so this is kind of pattern. Now how do we go about it? So let us look at the context. So if you look at the first context, patient reports taking rapid acting insulin. So this is a patient who is on insulin. So if he is taking rapid acting insulin before bedtime, so what could be the action that is required? So we need to either reduce or stop the bedtime rapid acting insulin, or you can reduce basal insulin, or both. So this all depends upon what is to be done depending upon the patient's glycemic pattern. If patient is not taking rapid acting insulin but taking only an basal insulin at night, probably you have to reduce the dosage of basal insulin, or if he is on a pump, you have to reduce the basal rate of the infusion that is going on, or very important is to change the time from bedtime basal insulin, convert it to a daytime or a morning or AM insulin, basal insulin. If you are looking at hypoglycemia after meals, what is the context? Patient is taking mealtime insulin, so probably we need to reduce the mealtime insulin, the prandial component, or if the patient says that he is skipping the meal or he is taking the meal at erratic times, I think we need to fix the timing. So here we need to talk about the support system that is having. Why is that this gentleman, senior person, not having his meal at the proper time, and why is he skipping? So this is where we need that conversation to happen, and probably reinforce the importance of taking insulin based upon the meal time. And if you are looking at an hypoglycemic episode following a period of hyperglycemia, what is the context? Patient is taking correction dose. Here patient, because of the sugars were around 45 or 50 at mealtime, he skips the insulin at lunchtime. Then at 4 o'clock, he suddenly is seeing the sugars have gone up to 350. He is having a CGM, so he gets scared, and definitely he takes a prandial dose, that is the correction dose that we call it, on his own, and for which probably the patients have family physician also given him to take 2 to 3 units. Unfortunately for him, by that time, there he goes for an hypoglycemic event. So we need to stop this correctional dose at this age group. For an young person, for people who are 45, 50, healthy, type 1 diabetes especially, they can take this correctional dose, but not for an elderly people. And once you have the CGM, now we have the Liberate 2, the new version has come in. We also have other companies we can share the CGM data live. So I have a patient, I have in my system or in my mobile phone the continuous glucose monitoring data right now live, what is happening to my patients. So if we are able to share that immediately, I think probably we can talk to the relative or to the patient that what is to be done so that we can prevent hypoglycemia. So in older patients with type 2 diabetes, I think the drugs which are already available like GLP-1 receptor agonist, metformin, the dual GIP or GLP-1 receptor agonist, SGLT2 inhibitors, all these drugs including thiazolidinediones. Of course, a caution is to be exercised when you talk about thiazolidinediones. They of course carry a lower risk of hypoglycemia compared to sulfonylureas, glinates and other forms of insulin. And medications such as SGLT2 inhibitors and GLP-1 receptor agonists as well as the dual agonists are preferred for patients with atherosclerotic cardiovascular disease as well as CKD, as long as they don't compromise a person's overall well-being. Very, very important. So you will have to take whether it is doing harm or benefit in such patients. So for an example, a patient is on GLP-1 receptor agonist to reduce his cardiovascular event. He begins to lose excess amount of weight in the process. I think in these patients it is better to discontinue GLP-1 receptor agonist than continue, because you know that his physical activity as well as protein intake may not be as what we want at this age group. Yes, same as with SGLT2 inhibitor. Even if the patient has a heart failure, but he or CKD with proteinuria, and that is what we require in SGLT2 as one of the guideline directed medical therapy, but he has recurrent urinary tract infection or he is not able to take fluid appropriately, which can, because he is dependent on a caregiver, I think that volume depletion might be severe enough to outweigh the benefits in older patients when they have these comorbidities. So this is where our personal medicine decision making come into practice. And this is going to be my last slide. I have 4 minutes, so it's a busy slide, but I can just go through it. Where is my laser pointer? Here. So if you are having a stress or a distress that can happen to a patient, always look for two important things. A, whether the patient has hypoglycemia, or B, whether there are some comorbid condition that is associated apart from hypoglycemia. If it is going to be a hypoglycemia related event, then always look at the prescription, whether the patient is on sulfonylurea or on a glinide, and if that is the case, please kindly remove the sulfonylurea or reduce the dose of sulfonylurea as the case may be, and go or replace with a preferred agent. This preferred agent we can talk later. If the patient is on insulin, either as a basal insulin, then already I think we have discussed in the previous case that you change the dose from bedtime to morning, or you titrate the insulin, lower the dose of insulin depending upon the fasting blood glucose. If the patient is on basal bolus regimen, probably you can take off the basal, you continue the basal regimen, and probably you can decrease the bolus or the prandial insulin, or maybe you can take off once the patient's target goals have been achieved. So if the patient is having split insulin, premixed insulin, give the 70% of the insulin probably the daytime and probably only 30% the nighttime. It doesn't mean that we have to equally split. When we had our premixed insulin before the analogs came in, we had the usual of 2/3, 1/3 concept in the morning. Probably you can look into that concept if required for that particular patient based upon the glycemic pattern. And if you have a patient on OHA, and it is not hypoglycemia related, but something that can probably give in distress, I think please look at his kidney function. And kidney function has to be looked on is looking at his EGFR. If EGFR is less than 30, probably you have to or avoid metformin, definitely stop sulfonylurea, and do not start SGLT2 inhibitor on an elderly person with this EGFR. And now number 2 is to look at his appetite. If appetite and the weight to some extent, if appetite is normal and there is no harmful weight loss, probably you can go ahead and give DPP-4 inhibitor or a GLP-1 receptor analog. But if a patient has a low appetite, low weight, and there is going to be an harmful weight loss, preferably a DPP-4 inhibitor would be an ideal replacement for his sulfonylurea. If the patient GFR is greater than 30, you then again assess his appetite and weight. If his appetite is low and he has low weight or harmful weight loss, stop metformin, GLP-1 receptor agonist and SGLT2, and preferably again go for DPP-4 inhibitor. Now you can see that DPP-4 inhibitor becomes a much more a commoner drug of a preferred drug of choice in elderly population compared with as a preferred agent of replacement for a sulfonylurea. And thiazolidinones can be thought of, but be very careful when you start thiazolidinones because most of them are osteoporotic. I think Professor Lakshmanan is here right now, next talk, so probably he may not agree to be taking care of a thiazolidinone, but may be thought of as a second or third line drug of choice in that particular patient if he is lean. So, if the patient has a normal appetite, no harmful weight loss, then probably you can go for metformin, GLP-1 receptor, then all the drugs, because his EGFR is good, his appetite is good, probably these are the drugs which can be thought of in the form against sulfonylurea. So, the take home message, my dear colleagues, is that the care providers for older adults must be equipped to respond to the changes that come along with aging. Art of de-prescription. So, this is something that we have, this is what I thought I should emphasize the last 20 minutes. De-escalation should be the art to be looked forward, and in such patient, a setting of a holistic strategies must be implemented that can be tailored to individuals' current health status, adjusted according to medical, functional and social circumstance. So, CGM becomes a very important. So, every trigger that comes in, a fall or an MI or a hospitalization, please go ahead and advise a CGM for this patient. Just not have a strategy based upon HbA1c. Thank you for your patient listening.
Thank you, Dr.